Hello.
No, not that. What? I think you want me to say just make sure. Just actually learned from
Yeah, same here. I literally just got mine done.
Yeah, I still have it. Yeah,
You have a special couch for it.
Yeah, I'm getting a blister on my knee. Yeah, so this summer I have to get American like I work for I hear it's a
Anticipation.
She's already certified like full time. So like
That should be all right.
yes, not this summer, I get and it looks like we get that's what I think. No? Yeah.
If we wrote it on there, we just don't did write it on. Dude, I see you.
I'll I don't think it's over there.
I definitely text you, but I really do have to. I love our voice.
Not necessarily true if you tell it. Say.
Yeah. That's so stupid. White shoes. Can I just be like white shoes? Oh, that's so cute.
Well, you should cover either.
So I'm not moving. Two bucks, it's one time.
What?
What?
Well, I suppose it's as good a time as any to get started. So some of you zoomed in Monday night. The roads were treacherous, to say the least. So I'm glad to see you back safely and sound and in one piece, your automobiles as well. Today, we're going to talk about inherited cardiomyopathies. We will talk about cardiomyopathies in general. That's what the handout is for. This will remind you of some of what you might have learned about cardiomyopathies, or if you didn't learn it, now's as good a time as any to learn it. And then we'll look in more detail at inherited cardiomyopathies. Distinguishing between the two is important. If any of you do family medicine or pediatrics, there's a good chance you'll see these in your population, and they're easy to miss. And in athletes, these can be the cause of sudden cardiac death. So catching them early is important, and catching them early can also help you treat them in a way that will prevent the heart from getting worse. So that's an important feature about these conditions. Let's have a word of prayer, then we'll begin. Father, thank you that we have a judge who judges justly. Thank you, Lord, that you yourself in your body bore our sin on the cross so that we might die to sin and live for righteousness. Thank you, by your wounds we are healed. Thank you that though we were sheep who have gone astray, we have now returned to the shepherd of our souls. We pray, Lord, now that you would shepherd us through this last part of this semester. In Jesus' name, amen. So cardiomyopathies manifest essentially in a heart that doesn't work anymore. They look a lot like congestive heart failure. So let me give you a couple of clinical vignettes to give an example of two people with cardiomyopathies. Let's start out with a guy, let's call him Arnold. He's 60 years old. He comes to the clinic. He has shortness of breath and he has lower limb edema. He's had that for about the past 3 months. He has a history of chronic hypertension, chronic hyperlipidemia, and chronic alcohol use. When you auscultate the lung with a stethoscope, you hear an additional S3 sound. So you split the second sound, S1, S2, you hear that S3 sound. That's that rubbing sound you get, the smack of the blood against that myocardium that is starting to dilate, starting to thin out. That's an S3 sound. That's indicative of congestive heart failure. When an echocardiogram is performed, the ventricular chambers are dilated and the ejection fraction is reduced. About what is a normal ejection fraction? Give me an idea. $72 is stellar. I'll bet you the men's basketball team, I'll bet you none of those guys have 72%. 72 is like outstanding. Now in the NBA, sure. College, sure. This college, no. At D1 schools, they're paid for basketball. Our guys aren't. Which is going to be more important? You guys pay for the No. They don't pay for your schooling. They pay for your room and board. You're going to get an education. It doesn't pay your way here. Right? You guys work hard, but you spend all day. On schools, they spend. So, okay.
Ese man era raro, se movía mucho. Se movía mucho.
A mí me va a decir que no es marica.
Stephanie, can you turn down your microphone? I'm hearing a lot of talking in the background. Cheers. Give me a normal range for ejection fraction. Let's try 50 to 60. How's that? Good. 50 to 60. Get below 50, you start to work. So this guy's ejection fraction is 42%. That's, you should be worried. All right, let's have another clinical vignette. Her name is Alexandra, She's 23 years old. She's a professional volleyball player. So you're doing that, pay attention. She comes to the clinic after multiple syncope episodes. What's syncope? Fainting. Fainting. Very good. Fainting. So she passed out during games. First, she thought it was just due to hydration. Dehydration. That's fair. Now she's concerned. There's a family history of sudden cardiac death. Ooh, doesn't sound good, does it? Echocardiogram shows asymmetric hypertrophy of the interventricular septum, but a normal ejection fraction. Both these people have cardiomyopathy. Both these people have cardiomyopathy. They have different types of cardiomyopathy. Let's take a look at the different types of cardiomyopathy. There's three types. There's dilated, hypertrophic, restrictive. Dilated, hypertrophic, restrictive. Let's start with dilated cardiomyopathy. This is the most common one. It accounts for about 90% of all cases of cardiomyopathy. In dilated cardiomyopathy, the ventricular walls become thin and weak. As a consequence, the ventricular chambers will dilate. Because the ventricular wall is thinner, muscular contraction is weaker. So the heart cannot pump efficiently throughout the body. Therefore, you have a systolic dysfunction, but diastole is normal. You have a systolic dysfunction, but diastole is normal. When it comes to the causes of dilated cardiomyopathy, most of your cases are idiopathic. Macy, idiopathic, what does that mean? Exactly right. The case, the cause is unknown.
They don't know.
Right. Okay, story. You know, in the Gospels, there's the, Jesus asks the teachers of the law about the baptism of John. Before I answer your question, I'll answer this one. Was John's baptism from God or was it from men? And then they talked to themselves. They said, well, we say it's from man, the crowd's not going to like us. We say it's from God, he's going to ask us why we didn't follow John. So they said, we do not know. And so I always tell my quizzers, never sit down without saying anything. And so they what did the teachers of the law, somebody pre-jumped it, they got it wrong. And then because the other two quizzers had quizzed out, it was one person left on my team. We were doing pretty well that quiz. What did they say about John's baptism? And the quizzer said, he just said, I don't know. And he sat down, he got it right. There are lots of other secondary causes where it is clear. Toxins that affect the viability of the myocardium can thin it out. Things like alcohol. So alcohol abuse can cause dilated cardiomyopathy. Cocaine abuse can cause it. So can nutritional deficiencies. So, question you might see on the NCLEX, anorexia nervosa can predispose someone to dilated cardiomyopathy. Thiamine deficiencies, so beriberi. Selenium deficiencies, those can cause dilated cardiomyopathy. Another cause is myocarditis. The infection can kill off cardiomyocytes. That thins out the wall. So the big one is Coxsackie-B virus. But nowadays, SARS-CoV-2 can affect the myocardium, can't it? That can cause thinning of the walls of the heart. Autoimmune diseases, systemic lupus erythematosus, otherwise just known as lupus. Remember from pathophys, lupus can affect multiple tissues. And often the type of lupus someone has varies from person to person. With some, it affects their liver. With some, it affects their kidneys. With some, predominantly affects their skin, their eyes. With others, it affects their heart. So that can cause dilated cardiomyopathy. Hemochromatosis, a disease we've already discussed, where you store up lots of iron. One of the organs in which you store up lots of iron is the heart. Are you guys familiar with something called the Fenton reaction? Ever heard of the Fenton reaction, anybody?
No.
The Fenton reaction is the reaction of biological molecules with iron. It oxidizes them and turns them into things that your body no longer recognizes and that the cell can't use. So excessive amounts of iron are very dangerous. That's why your body has really exquisite mechanisms for storing and transporting iron. You have an entire protein system in your blood, transferrin, that's dedicated to moving iron around your body. You have hemosiderin that's dedicated to storing iron. Iron all by itself, nasty, nasty, nasty oxidizing agent. Your body has lots of ways to put cages around iron to make sure it doesn't do that, even though your body needs it badly. But your body makes sure that it essentially, it's like carrying a radioactive isotope. It's called a pig. It's made of lead. You put the isotope in the lead pig, and that's how you carry it around because the lead will shield you from all the radioactivity. That's where your body treats iron. It puts it in kind of a lead pig, if you will. All these things that store iron, transport iron, that's how it prevents iron from damaging things. Chagas disease. Chagas disease is caused by Trypanosoma cruzi. You get Trypanosoma cruzi by the bite of a rejuvid bug, otherwise known as the kissing bug. The kissing bug bites you, takes a blood meal, and then takes a dump next to the wound. It itches, so you scratch it and you move the trypanosomes into the wound. This is endemic to South America. So if someone has traveled to South America recently and they start having heart issues, that should be a tip-off. They might have other sort of symptoms too, periorbital swelling. This is a disease that affects soft tissue. Megacolon, megaesophagus, things like that. Pregnancy. Some women get this during the 3rd trimester of pregnancy. It's reversible. This is called peripartum cardiomyopathy.
Like the stress.
Yeah, because the mother's body demands more cardiac output, and sometimes the heart can just fail to meet this high demand. If it occurs in the last trimester of pregnancy and up to 6 months after delivery. So this reverses usually. The other thing that can cause dilated cardiomyopathy are chemotherapeutic agents that can damage the heart. The big culprit is doxorubicin, but you also see this, albeit rarely, but you see this with women who've been treated with trastuzumab. That's a monoclonal antibody used to treat certain types of breast cancers that are HER positive. Severe emotional stress can also cause cardiomyopathy. This is called Takotsubo cardiomyopathy. And that seems to be due to the flush of catecholamines over the myocardium. Any questions about dilated cardiomyopathies? So it's damage to the myocardium. That damage to the myocardium thins out the walls get thin, and the ventricles dilate. So the contraction is weak, you have a systolic dysfunction, but diastole filling is normal. Can they feel the damage? I'm sorry? Oh, can they heal the damage? Some of this is reversible, like the peripartum cardiomyopathy. Typically, when you're older, after it's been damaged with toxins or things like that, it's not reversible. Next is hypertrophic cardiomyopathy, and these are inherited typically. Now, unlike with dilated cardiomyopathy, in this case, the heart muscle thickens, and it thickens in a concentric fashion. So the cells will make more myofibrils. They're stacked one on top of the other. But if we look at some of you who are athletes, very good chance your left ventricle is enlarged as an adaptation to athletics. If we look at your cardiomyocytes and your fibrils, they're going to be nice and organized. When you look at someone with hypertrophic cardiomyopathy, you see something like this. It's disorganized, it's in disarray. And that sort of thing is, of course, quite abnormal. So what kind of mutations can cause this kind of condition? The ones that are most commonly affected are listed on your handout. So there are mutations in the beta-myosin heavy chain. So these tend to be mutations in genes that encode sarcomeric proteins. Rebecca, what's a sarcomere? Sorry? Caitlin, remember what a sarcomere is? Does anybody remember what a sarcomere is? So when the muscle contracts, it contracts in units. You have these repeating units, and those units contract. That unit is called a sarcomere. You have the heavy chain and the light chain, and the heavy chain moves across the light chain, and the sarcomere shortens. And the sarcomere has two sides that are essentially mirror images of each other. And that unit that contracts is called a sarcomere. Same thing with cardiac muscle. You have the cardiac sarcomeres. That's why cardiac muscle is striated, even though structurally it's different from skeletal muscle. So you have mutations in the myosin-binding protein C and the beta-myosin heavy chain. Those are the two most common. Also mutations in troponin, cardiac troponin, either troponin T or I. Also mutations in cardiac tropomyosin. Don't remember what these proteins do, please review. Get your A&P book out. Please tell me you didn't sell it back. And review. Guys, keep your textbooks. Keep your textbooks. You're going to need to do CME. You're going to need to look stuff up. Oh yeah, I can just look that up online. A lot of the stuff where you can look it up online now are charging. You have to have accounts. You paid for the textbook, keep it. Keep your textbooks, don't sell them back. All right, if it's your English literature textbook, I won't chew you out, but your medical textbooks, keep them. Don't sell them back. Plus, you're familiar with them and they've got all your scribbles in them. You do take notes in your textbooks, don't you? Okay, right now you're going to start taking notes in your textbooks and you're going to keep your textbooks. Okay? Thank you. At least Aaron said she would. I got one of you saying that. All right, also cardiac actin genes. Mutations in cardiac actin genes can also cause these types of hypertrophic cardiomyopathies. Now, you might think that a thick ventricular wall is a good thing, but there's a problem. Because the walls are so thick, the heart can't relax and fill during diastole. So systole is normal. It's diastole that's dysfunctional. Systole is normal. Diastole is dysfunctional. So ejection fraction will actually be normal. It might even be better than normal, but you still have a cardiomyopathy. And then the other one I have down there is Friedreich ataxia. Friedreich ataxia is mutations in the frataxin gene. Frataxin is the major chaperonin for iron in the mitochondria. It's the protein that gives iron to proteins that need to incorporate iron into them. Proteins like myoglobin, proteins like cytochrome, proteins like things with iron sulfur centers, things like that. It gets that iron from frataxin. So frataxin is the helping hand that gives the iron to those proteins. Mutations in frataxin cause Friedreich's ataxia. Friedreich's ataxia tends to not cause problems until people get older. When they hit middle age, they start having, well, ataxia. Sydney, tell us what ataxia means. Taxi. Taxi means move, right? So ataxia, don't move properly. You don't move properly. Movement problem. Movement problem. Okay, Friedreich's ataxia, yeah.
So back to the dysfunction. The walls are so thick that they like can't like begin enough or release enough.
Right, the space to fill is now greatly diminished.
Okay.
So you don't fill properly. Because you don't fill, you have this backup into the lungs and other places too, and the aorta in particular, as we're going to see, is particularly affected. Now, if the septum gets enlarged, it gets enlarged asymmetrically. Take a look at what that does to the outflow. It stenoses the outflow, doesn't it? And then take a look at what happens to your mitral valve. See how this gets pulled down? So one of the cusps of the mitral valve now, so the mitral valve has these two cusps, one of them is now going to get pulled. So instead of closing like this, it's not going to close properly, is it? So that's going to cause mitral valve regurgitation. And you now have outflow issues into the aorta. So this is called hypertrophic obstructive cardiomyopathy. Got too ahead of myself. Hypertrophic obstructive cardiomyopathy, or HOMC. HOCM is the #1 cause of sudden cardiac death in people younger than 35. So you hear these news stories. Some Norwegian soccer player all of a sudden falls on the pitch in the middle of the game and dies suddenly. Turns out some of those people have this hypertrophic obstructive cardiomyopathy. Now, those athletes are heavily screened. If someone missed that in a screening, they should be beaten with a wet noodle. Better yet, they should be fired. They should lose their job because that's one of the things you're going to screen intensely for. The next type of cardiomyopathy is restrictive cardiomyopathy. In this case, the heart muscle gets stiff. Because it gets stiff, it can't relax during diastole. So once again, you have diastolic dysfunction, but relatively normal systolic function. The primary causes are idiopathic. So endomyocardial fibrosis, where all of a sudden you get this excessive collagen deposition in the heart muscle. That's a type of restrictive cardiomyopathy. And then this so-called Loeffler's eosinophilic endocarditis, where the heart gets infiltrated with eosinophils for reasons that no one understands. Other secondary causes include amyloidosis, the deposition of this amyloid stuff all throughout the heart. Amyloidosis can affect any tissue, but if it affects the heart, then you get a restrictive cardiomyopathy. And then sarcoidosis. The other main cause of it is radiation therapy. Any sort of radiation therapy to the chest area can damage the heart and it's replaced with scar tissue with collagen. That can cause a restrictive cardiomyopathy. So on the NCLEX, you get a 72-year-old lady who's a breast cancer survivor and was treated with radiation. She comes in with heart failure symptoms. Your head goes to restrictive cardiomyopathy. Very good. So let's talk a bit about the clinical presentation of cardiomyopathy. So you have the basic signs of heart failure. You have fatigue, dyspnea, swelling of the feet. And because these cardiomyopathies also affect the conducting system of the heart, arrhythmias are very common. So things like atrial fibrillation, ventricular ectopic beats, ventricular tachycardia or ventricular fibrillation, or AV block, atrioventricular block. Madison, what does an AV block look like on an EKG? What would you not see? First of all, what would you see on a normal EKG? Okay, you guys ready for next year? So a little review. I know it's painful, but your preceptors and your clinicals are going to be. Okay, Natalie's got some idea going here. Okay, but yeah, you've got it. What? Go ahead, tell me.
It would be like.
Well, good. Come here, draw it. Come here, draw it. Come on. Natalie.
Kind of like this.
Doesn't have to be pretty, just accurate.
Like that.
All right, that's kind of abnormal. Okay, what you've drawn is QRS.
Oh,
Okay, there's two other blips on there, aren't there?
Yeah.
You got
T.
you got QR. Okay, where's P? Where's P? P is atrial defibrillation. depolarization. Does that occur before or after ventricular depolarization?
Before,
Right, so that's gonna go
here,
here. Okay, go ahead, put it in.
okay, I'm not sure what that looks like though,
It's just kind of a small blip.
like that, kind of,
It's bigger than that, but okay.
okay.
All right, then you have ventricular repolarization. Okay, that's fair.
Okay.
And that's your T wave.
T-wave.
Does depolarization come before or after? Repolarization come before or after depolarization?
After,
After, so put your T wave in.
so that would
That'd be after QRS. So,
QRST.
right, go ahead, put your T wave in. Good, good. Okay, go ahead and label them. Label them. P, Q, R,
Oh, where is
Q, R, S,
T?
T.
P-
Okay,
Wait, this is R, or this is Q.
right. Q, R, S.
Okay, got it. No, oh
R.
my word.
R,
I'm
R,
having
R.
problems.
R, the ridge of the mountain, R.
There we go.
Okay,
Got it.
all right, now, you can go ahead and sit down. Thank you, thank you. Natalie's very brave. All right, now if you have a block, you have an AV block, the beat can't get from the atria to the ventricle. So what are you going to see? Sorry? Yeah, yeah. You might see, if it's a complete block, then you might just see the P waves, and then you'll get an occasional QRS because a bundle of His takes over, but it beats much more slowly than the atrial pacemaker. Or you'll see regular ones, and then occasionally a QRS goes missing. That's because there's type 1, type 2, Mobitz 1, Mobitz 2, so on and so forth. So those are blocks, essentially. Those things you're going to see. You might see those with these types of cardiomyopathies, an AV block. Now, with the hypertrophic obstructive cardiomyopathies, something that will be very common are syncope events, fainting, passing out, transient loss of consciousness. You don't have good perfusion of the brain because of this outflow issue. So individuals will present with syncope. That's a clinical picture. Now for diagnosis, the gold standard is going to be echocardiography. But with auscultation, with dilated and restrictive cardiomyopathy, you'll hear an S3 sound. That's a result of the blood rushing and slamming into the dilated ventricular wall during diastole. With hypertrophic cardiomyopathy at the apex of the heart, you'll hear an S4 sound. That S4 sound, it's not specific for hypertrophic cardiomyopathy, but you hear a systolic murmur between S1 and S2. And this systolic murmur is a crescendo decrescendo, like that. So it gets louder as the blood rushes out and then softer. Furthermore, it will change. So let's say you do a maneuver that causes systemic vascular resistance to increase. Say you squat, or say you do a hand grip maneuver. Say you give them your fingers and say squeeze. That sort of thing is going to increase systemic vascular resistance. That makes it harder to eject the blood out. It increases the afterload, but the ventricle now has more blood stretching it out. So it becomes less obstructed. So if you stretch this out more, it gets less obstructed. So the sound, the systolic murmur, softens if they squat or they do the hand grip. That's a key component with this type of cardiomyopathy. If, however, they stand up or they do a Valsalva maneuver, they bear down like that. Now the venous return will decrease. If you decrease preload, you don't stretch the ventricle out as much. Now the sound gets louder. So with squatting or hand gripping, the sound gets softer. The systolic murmur gets softer. With a Valsalva maneuver or standing up, it gets louder. And then with the mitral valve regurgitation, you might hear a so-called holosystolic murmur, meaning that it lasts throughout systole. So instead of dunk, dunk, you just have bzz, 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 like that. And that's a holosystolic murmur, which is characteristic of a mitral valve regurgitation. In the EKG with restrictive cardiomyopathies, your QRS wave is going to be short. It'll be short. You have low voltage essentially in the myocardium. So if you do an echo, you measure the thickness of the walls, the dimensions of the ventricles. For dilated cardiomyopathy, you'll see left ventricular dilation and low ejection fraction, since you have asystolic dysfunction. Left ventricle dilation, low ejection fraction. For hypertrophic cardiomyopathy, you'll see increased ventricular wall thickness, normal ejection fraction, at least in the early stages of the disease, and then in restrictive cardiomyopathy, the shape and the dimensions of the heart will be normal, but the movement of the heart will be diminished. So to treat this, you treat the congestive heart failure just as you would congestive heart failure. Beta blockers, ACE inhibitors, sodium restriction of the diet, diuretics. If the heart can't beat fast enough, hard enough, you give digoxin. But for people with hypertrophic cardiomyopathy, one, you have to cease high-intensity athletics. That's to avoid sudden cardiac death. You treat arrhythmias with your non-dihydropyridine calcium channel blockers, things like verapamil or beta blockers. But you want to avoid drugs that prevent the stretching of the myocardium, because the less you stretch this, the more obstruction you have. So you want to avoid nitroglycerin, you want to avoid ACE inhibitors, and you want to avoid dihydropyridine calcium channel blockers. And then digoxin is also contraindicated because it increases the force of contraction, so that can actually increase the obstruction as well. Patients will usually need a pacemaker implanted and usually an implanted defibrillator. Some may need eventually a left ventricular assist device. And I don't have this on there, but if things get really bad, they'll need a heart transplant. Okay, let's go back to our little clinical vignettes. Arnold, shortness of breath, lower limb edema, history of hypertension, hyperlipidemia, and chronic alcohol use. Ooh, alcohol. What's that? That tips you off to what? Aha, good job. Auscultation, you hear S3. Reduced ejection fraction on echocardiogram with dilated ventricular chambers diagnosis. Dilated. Very good. Exactly right. Alexandra, our 22-year-old professional volleyball player. She had syncope. Family history of sudden cardiac death. Echo shows asymmetric hypertrophy of the interventricular septum, but a normal ejection fraction. Diagnose her. HOCM. Hypertrophic obstructive cardiomyopathy. So now let's get to the, Caitlin, the question, is there a question?
It's HOCM or HMOC.
I keep saying it wrong. CM, cardiomyopathy, CM. Do I have it wrong on the handout?
You gotta go right. It's both
I had both ways because I was on drugs while I was writing this, so yeah. No, cardiomyopathy. Hypertrophic obstructive cardiomyopathy. Huckum.
So, like, there's this guy in my hometown, in my high school, and he was Northern Michigan, and he died of HOCM after working out, and then he got endocrine, and he was on this worm, and that they died of HOCM. Like, they said like he didn't have any symptoms, like everything
Yeah.
seemed normal. Is that common? Like,
That's why it's called sudden cardiac death.
What happens like in the heart? Like
The obstruction, essentially, you don't get proper perfusion of the tissues. That includes perfusion of the heart itself. You essentially get an ischemic heart attack. And it can be, in a young person, heart attacks are more severe than they are in older people. And so because you don't properly perfuse the heart itself as well, that ischemia just gets worse and worse and worse. And then you get this large amount of damage that occurs just all of a sudden. And that's essentially what causes it.
So they would show like no like symptoms prior to this.
They need an echo. That's why, guys, family history. Got to do a family history. And that's what you guys aren't going to be doing the echoes. You'll be interviewing the patient. You got to do a family history. You have to. It has to be complete family history. Tell me everything. Don't make any assumptions. Just give me the news. Don't interpret it. Just tell me the news. Your job is to write it down so that the clinician has all the data that she needs to be able to make a proper assessment. That's why your relationship with the patient, your people skills are going to be as important as your knowledge of medicine. Got to do a good family history. It's really important. Yeah.
So like say you're at like a game and an athlete does drop and have this. If you were to pull out an AED and put that on the field, is that something that could save them? Or
Yeah.
like, oh,
It
yeah.
could, yeah, in a case like that, because the only way the heart will be perfused is if it starts beating again.
So once it has all the scar tissue from like the ischemia, how do you?
The scar tissue doesn't set in until the heart. It takes about 6 minutes for the cardiomyocytes to start to die. And when they start to die and then they dump essentially their materials into nearby cells, that's when cells really start to die. Not unlike what you get in stroke, where some just small amounts of neurons will die, but then as they dump their neurotransmitters, they get this excitotoxicity. And that's why the stroke, the destruction will essentially be concentric from that one area. That's why getting treatment ASAP is so crucial to make sure the area of damage is really, really small. Same thing with heart damage. If someone's heart stops and you start it up relatively quickly, they can actually not have much damage at all. That's why it's so important if someone has chest pains, they get to the cath lab ASAP. So my colleague, Tom Kunzelman, his wife's a nurse, which helped, I'm sure. But Tom was having symptoms. Tom was in the cath lab in 20 minutes. So that's why Tom has essentially no damage to his heart. He's got his stent that was put in because he's got this goofball set of coronary arteries on his right side. which that's what got plugged because it's like a knot essentially. Imagine putting this in there. But because he got to the cath lab so fast, he's fine. He still has to go through the what have you, the rehab and everything, and on his medical records, it'll say he's a heart attack patient, but I'm sure he'll be back out on the bicycle course, riding his bike and beating us all and so on and so forth before long, because Tom's heart has virtually no damage. So, yeah.
With COVID, like, I'm sure a lot of young athletes like have.
Yeah.
Hypertrophic too, would it be like dilated as well?
No, that'd be dilated because of the death of the cardiomyocytes. And the thing is, you're young and healthy, you don't have any symptoms. Because your heart can take the death of a few cardiomyocytes. So it's not until you start getting this death en masse that you really start to get an issue with the heart, especially when you put greater demands on it. That's why you see people dropping during a game or after a game when the heart is trying to recover. And I can't tell you how many people I blocked on Twitter because I said, these people would come up and say, oh, all these soccer players are dropping dead, it's a vaccine. Okay, can you link me to the autopsy report that showed me that it was vaccine related damage? Oh no, well, it had to be the vaccine. No, you're assuming. You show me the autopsy report. Blah, 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 abuse. No, you made a statement. Can you back it up with evidence? Can you give me evidence that this assertion that you made is actually based in science and not your bullcrap? Abuse. Okay, I'm blocking you. This is unproductive. And the conversation after conversation after conversation has told me that people say these things and they have no evidence. So these people are heavily screened, and after they drop, they get an extensive autopsy. And only then can it be determined if the damage essentially was due to the vaccine. Because then you'd have antibodies and you'd have the RNA from the vaccine in there, and that's not been the case.
Does the vaccine like prevent like more damage like, to the heart?
It's supposed to protect you from COVID-19, but some people are saying that the RNA lasts for centuries and so on and so forth, or some other baloney. What have you. We know how long the RNA lasts in your body. It's not that long. So anyway. So some of you will do sports medicine and things like that. These are things to be aware of. All right, so the two different types of inherited cardiomyopathies that this chapter talks about, one of them is a so-called arrhythmogenic right ventricular dysplasia / cardiomyopathy. And with this particular condition, this is due to mutations in proteins that form this thing called a desmosome. Did you guys talk about desmosomes in A&P? So you've heard the term before. You heard the term, okay. So a desmosome is used by cells to attach to the basal membrane. And then desmosomes can also be used to attach cells to each other. So it's found in epithelial cells, but it's also found in contractile tissues. And so mutations in protein, in genes that encode proteins involved with the formation of desmosomes, will cause this type of arrhythmogenic right ventricular dysplasia / cardiomyopathy, which is mercifully abbreviated ARVDC. There are some rare forms of this condition that are autosomal recessive, but the more common forms are autosomal dominant. The recessive forms is called Naxos disease. It's called Naxos disease because the first people who had it were from the Cycladian island of Naxos. And these are, again, mutations in proteins, desmoplakin, plakoglobin, things like that, that are necessary to make desmosomes. The more common ones of these are autosomally dominant. Now, if you don't have the cells properly stuck together, their ability to beat is not affected, but their ability to beat in a way that's coordinated, their ability to be connected together and pass the signal to beat in a coordinated sequential fashion, that's going to be pretty cocked up, isn't it? And that's why this is arrhythmogenic. So arrhythmias are the big feature, essentially, of this condition. You see this about 1 every 1,000 to 2,000 people. So it's not super common, but it's common enough. It's the second most common cause of sudden cardiac death in people younger than the age of 35. The most common is the hypertrophic obstructive cardiomyopathy. This is the second most common. This can be completely asymptomatic. That's why this can be dastardly difficult to diagnose, easy to miss. If it's symptomatic, then you have arrhythmias and palpitations and chest pain and fainting and blah, 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 blah. But on the whole, it's not easy to diagnose, and it's really by getting a good family history that you're going to be able to get your head around this one. And again, that's going to be your job to get that family history. So if you have sudden cardiac death in any first-degree relatives, that should start your spider sense tingling. And then other types of indications, heart failure, hypertrophic cardiomyopathy, heart transplant, strokes, white clots, things like that. Because an EKG, the EKGs for these patients are all over the place. There's not one EKG I can point you to say, yep, that's what ARVDC looks like. No. And some people, their EKG will look kind of normal. And then all of a sudden their EKG goes on drugs for several cycles and then it's normal. Do you have any symptoms? No. My heartbeat was a little heavy, but. So you get really wide variation in the manifestation of this particular condition. So in terms of physical findings, you'll have an S4 sound. So that's the systolic murmur. So-called brisk carotid upstroke. During systole, when you feel for the carotid pulse, instead of just a pulsation, you'll get this thing that will really cause your finger to move. Prominent left ventricular apical pulse, a lot stronger than you'd find in a normal person. And then at the apex of the heart, a so-called apical lift. Those are things you'll find, but you don't find each of those in every patient. And the EKG is abnormal, but the way it's abnormal really varies. Now, the hypertrophic cardiomyopathies that are inherited, those again are due to mutations in the sarcomeric genes that encode sarcomeric proteins. So again, with this condition too, it's going to be a family history because you get reduced penetrance. Not everyone who should have the condition has it. Also, some people are completely normal when they're younger, and then all of a sudden they get older and they fall off a cliff, cardiologically speaking. So I know you're saying, Dr. B, this really doesn't sound very fair. It sounds like it could be a lot of things. Yep. And that's why a family history is going to be so important. So with the ARVDC, there's the 4 different phases. So extensive cardiac testing with a Holter monitor for a day. You've probably seen a Holter monitor? Any of you? You wear them. They're you strap and a power pack, and it takes your blood pressure and it measures your heart rate. And it's kind of bulky. Oh, they've gotten smaller. They used to be really bulky and a big pain. They're smaller now than they used to be. Cardiac MRI, stress test, 12 lead EKG, blah, 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 and then other types of tests. Myocardial biopsy, that's kind of a last resort if you just really don't know. So with the hypertrophic cardiomyopathy, the age of onset is usually between 20 to 50 or so. They say 19 to 45 is about 20 to 50. And you'll get the extra sounds, S3 and S4, and that S3 sound is pretty loud. Fortunately, the genes for these are pretty well identified. There are good tests for them, and you can get them tested essentially in a, the lab will do this mass screening that will screen all the different genes involved. So when you order these types of tests with the ARVDC, a very common feature is you get replacement of myocardium with fibrous fatty tissue that replaces it. That's why a biopsy is going to be pretty important, at least with that particular condition. That's a feature of that condition that's pretty unique. Pretty unique. And the diagnosis requires 2 major criteria, 1 major, 2 minor, or 4 minor, given the criteria that are listed in these tables here, and yada, yada, yada. So you normally inherit these in an autosomal dominant manner. There's a rare form, it's recessive. So the evaluation, you do this, these screens are done en masse. There's 12 different genes that are linked to the hypertrophic cardiomyopathy. There's at least 8 known to be associated with the RVDC. The screens usually will detect the mutations. I'm trying to think if there's mutations that these screens will miss. Usually not. Usually not. If the company gets a result that's indeterminate, it usually will retest it. And unless it's a really new allele that's not yet been associated with the disease, then the company may say, there's an allele here we've not seen before. It's not seen in people without the disease, but we don't know if this will cause a disease. So you get some uncertainty. But in most cases, these screens can identify mutations that cause a disease. Unfortunately, there's no treatment. So most of the treatment, you're going to have an implantable defibrillator and what have you. If the patient gets any dental care or anything like that, their chances of getting infected heart valves is pretty high. So prophylactic antibiotics is very important. They will also need anticoagulants on a regular basis. Because of the arrhythmias, that puts them at increased risk for clots. They may just need a heart transplant. People with this condition are pregnant. It's a high-risk pregnancy. That's all there is to it. Dyspnea can be treated with drugs that will slow down the heart in the case of the hypertrophic cardiomyopathy. And the heart transplant is really the only way to deal with these. There are other conditions that can do this. Fabry disease is a lysosomal storage enzyme disease. And because you're unable to break down these particular lipids, that lipid can accumulate in the body and it can deposit in the heart. It deposits other places too. And Fabry disease occurs, it's X-linked, so it occurs in males predominantly. That can cause conditions that are like unto these particular conditions. And then some other ones that are associated with this ones we've kind of talked about before. All right, so those are the inherited cardiomyopathies. Marfan syndrome is next. We've talked about Marfan syndrome a bit already. I'll blow through that pretty quickly. And then comes polycystic kidney disease. We can get through that pretty expeditiously. And then after that is, I forget. I am probably going to set up a discussion forum on Blackboard for you to submit questions for our final, because the final is coming up in less than a month. So you'll be able to submit questions come finals. So be thinking about questions even now. Bree? I'll let you know on it. Right, no, I'll let you know on that. Yeah. No, just the stuff we've covered since the last test, which is more than enough. It'll be in class. It'll be in class. Is that a problem?
It's not a week, so it's like not last Monday.
It is, yeah.
It is?
Yeah, string our scheduled final. That's what you asked, right? Bree, what did you ask?
Because I know there's like final blocks, so like that Tuesday, Wednesday.
When we're scheduled to take the final, that's when our final will be.
Oh, I didn't know if it could be like in a class, like in the class or in that final. Like,
It'll be in the finals block.
okay.
Yeah, yeah. Okay, Steph, I'll email you with times to be able to come in and take those makeups. I have lab in the morning, so I'm available in the afternoon. Does that work for you?
Yes, that's fine.
Okay, then I will look for you tomorrow afternoon. I'll be in my office.
Okay.
Do you
Thank
know where
you.
my office is?
No.
203 Whiteman Gibbs, so it's upstairs
Okay.
in Whiteman Gibbs where we meet for class. It's upstairs, the upper floor.
Okay.
Just go
Sounds good.
upstairs. You'll find me. I'm not hard to
All right.
find.
Thank you.
See you tomorrow. Ciao.
Bye.